Welcome to the Deep Dive. We're your shortcut to getting truly informed. Today, we're diving into something, well, pretty complex, but really important. The world of anxiety, OCD, and trauma disorders. We've pulled together clinical notes, DSM criteria, treatment info, basically trying to give you a clear map.
Yeah, and it's a crucial map to have
Yeah.
because anxiety disorders, they're actually the single most common mental health issue globally. So our mission today is clarity. Let's try and distinguish these conditions, not just by name, but, by what's really driving them, the fear, the avoidance mechanism.
Okay, let's unpack this, though. Where do we even start? What's the first building block we need to understand here?
I think the absolute foundation is understanding the difference between normal fear and what we call clinical anxiety.
Right, our sources hit that straight away.
Exactly. Fear is that immediate gut reaction. You see a snake, hear a bang, it's right now. Specific, imminent.
Okay, makes sense.
Anxiety, though, that's different. It's more future-focused. It's about a perceived threat, something that hasn't happened. And often, the person isn't even totally sure what they're anxious about. That lack of a clear source makes the feeling itself the problem. It feels out of control.
So it's that persistent worry about the future, and if it starts messing with your life, like your job, your relationships, that's when it tips over from just normal stress into a disorder.
Precisely. Look, anxiety itself is normal. It's an adaptive response to stress, helps us prepare. But when it becomes excessive, when it sticks around, when it genuinely impairs your ability to function and degrades your quality of life, yeah, then we're talking about a clinical disorder.
Okay, and it's not like an on-off switch, is it? The sources talk about anxiety existing on a spectrum. That really caught my eye. These levels: mild, moderate, severe, panic. How different are they really?
Oh, they're vastly different. It really comes down to how much you can perceive and how well you can function. Let's start with mild anxiety, honestly. It can be helpful. Psychologically, your perception is wide open, you're more motivated, you can actually solve problems effectively.
No. So it gets you going.
Exactly.
Yeah.
Physically, maybe just a bit restless, those butterflies in your stomach people talk about, it's basically peak alertness.
Okay, so mild's good, almost. But then moderate anxiety, that's where things start to go sideways.
That's when the impairment really cooks in, yeah. Your perceptual field narrows, we call it selective attention. You start having trouble connecting thoughts or events on your own. Your focus shifts inward, trying to manage the internal feeling rather than the external situation.
And I guess that's where the physical side really starts to show up more strongly. We see that link across all these disorders.
Absolutely. At the moderate level, the physical signs are pretty undeniable. Muscle tension, maybe your heart's pounding, dry mouth, the body's alarm is getting louder.
Okay. Then what happens at severe anxiety? It sounds like things really shrink down.
They do. Your perception becomes greatly reduced. You really can't complete tasks. Problem solving. Pretty much impossible at this point.
Wow, what's that like inside? Mentally?
Psychologically, people might feel awe or dread, even horror. Insomnia is really common. And physically, the symptoms get, well, severe. Chest pain, bad headaches, dizziness, maybe standing really rigidly. Functionally, you're overwhelmed.
Right, just trying to hold on. And the top end of that scale is
Yeah.
panic.
Yeah, and panic it's chaos, basically. Perceptions get distorted, maybe even further reduced. Rational thought, gone. In really extreme cases, someone might experience temporary delusions or hallucinations.
Whoa.
Physiologically, this is the classic fight, flight, or freeze. Someone might literally bolt and run, or they might become completely immobile, frozen. Dilated pupils, the whole stress response maxed out.
Just total disorganization, pure survival mode kicking in.
Yeah.
So what decides where someone lands on the scale? Is it just how big the stressor is?
That's definitely part of it, sure. But the sources emphasize it's more nuanced. It's about the impact of the stressor. Is it a one-off thing, or is it chronic? And maybe even more importantly, it depends on the person's own resources, their defense mechanisms, their coping skills, their support system. All of that acts like a buffer. A strong network can really dial down the intensity.
Okay, that makes sense. Let's try and link this spectrum to the actual diagnoses doctors use. Like, if someone's stuck in that chronic worry state, narrowing their life. That sounds like generalized anxiety disorder, or GAD.
That's often the case, yes. GAD is characterized by that excessive worry. It's pervasive, happens more days than not for at least 6 months. And crucially, it comes with physical symptoms too. Things like tiring easily, finding it hard to concentrate, ongoing muscle tension.
And our sources mention something interesting, that GAD is what family doctors see most often, suggesting people might go in for the physical stuff first.
Exactly. They might focus on the headaches, the fatigue, the stomach issues,
Hmm.
not necessarily realizing the root cause is constant worry. And we actually measure this impact. Tools like the GAD-7 scale help quantify it. The example in our notes, a score of 12. That's significant. And the fact that they checked it made it very difficult to handle work or relationships.
Hmm.
It's not just a number. That's showing real, profound functional impairment.
Okay. Now, shifting gears slightly, panic disorder. It sounds like hitting that severe or panic level, but sort of out of the blue.
That's the key phrase, recurrent, unexpected panic attacks. This isn't just feeling very anxious. It's a sudden, overwhelming surge of intense fear. It peaks within minutes, and it comes with these terrifying physical symptoms, heart palpitations, feeling short of breath, trembling, shaking. And often there's this intense psychological fear too, fear of losing control, fear of going crazy, sometimes even feeling detached from reality, which we call derealization or depersonalization.
Wow. And it's not just about having one attack, is it? There's more to the diagnosis.
Correct. To meet the criteria for panic disorder, at least one of these attacks has to be followed by a month or more of either persistent worry about having another attack or significant changes in behavior aimed at avoiding triggers. Like someone might stop exercising because the feeling of their heart racing reminds them too much of the start of an attack. That avoidance is key.
Avoidance. This seems like a common thread. It definitely runs through phobias too, right? That intense, persistent fear of something specific.
Yes, phobias involve excessive and persistent fear tied to a specific object or a social situation, causing extreme distress and, again, avoidance.
And the sources call out one type as particularly severe, agoraphobia.
Yeah, agoraphobia is often misunderstood as just fear of open spaces. It's actually broader. It's the fear of being in situations where escape might be difficult or embarrassing, or where help might not be available if panic symptoms hit. And because people with agoraphobia often drastically rearrange their lives to avoid these feared situations, sometimes to the point of becoming housebound, it really is considered the most severe and persistent type of phobic disorder.
Okay, here's where it gets really interesting for me. We move from that more generalized anxiety or specific phobic avoidance into, well, the world of OCD and the way trauma fractures things. How is OCD different from something like GAD? The worry seems different.
It is different. While GAD is often characterized by free-floating worry about many things, OCD tends to be driven by a need for certainty or fears about specific, often disturbing possibilities. It's actually the fourth most common mental illness, and the diagnosis requires either obsessions, compulsions, or typically both.
Okay, so break those down. Obsessions are.
Obsessions are those thoughts, images, or impulses that keep coming back. They're intrusive, unwanted, and they cause a lot of anxiety or distress.
And the compulsions are the reaction to that, the attempt to make it stop.
Exactly. Compulsions are repetitive behaviors like checking, washing, ordering, or mental acts, like praying, counting, repeating words silently. The key is that they're performed to try and reduce the anxiety triggered by the obsession or to prevent some dreaded event. Even if the person knows it's excessive or irrational, they feel driven to do it.
And it takes up a lot of time.
That's a core criterion. For a diagnosis, these obsessions or compulsions have to be time-consuming, taking up more than 1 hour a day, or cause significant distress or impairment in their lives, their job, their relationships.
The sources also mention the DSM-5 now includes related disorders in this category, things like hoarding.
That's right. Recognizing the underlying similarity in driven repetitive behaviors, the category now includes hoarding disorder, trichotillomania, which is compulsive hair pulling, and excoriation disorder, compulsive skin picking. They share that compulsive quality.
Okay, let's make the transition now to trauma. This feels like it changes the brain's whole relationship with reality somehow. There are two main diagnoses here, starting with acute stress disorder.
Yes. Acute stress disorder, or ASD, happens within 1 month of experiencing a traumatic event. A key feature, something that distinguishes it, is the presence of multiple dissociative symptoms. It usually resolves within about 4 weeks.
Dissociation. Maybe we should quickly define that. Sounds quite dramatic.
It can be, yeah. Dissociation is essentially an unconscious defense mechanism.
Yeah.
You can think of it as the mind sort of checking out or creating distance when reality is too overwhelming or painful to process fully. It's emotional separation that protects the person in the moment. It can show up as feeling numb, detached, like the world isn't real, that's derealization, or even having gaps in memory for the traumatic event, dissociative amnesia.
Okay. So it's a short-term coping mechanism, almost. But if those kinds of responses last longer and become more embedded, that's when we get to PTSD.
Precisely. Post-traumatic stress disorder, PTSD, involves the persistent effects of experiencing or witnessing a traumatic event like actual or threatened death, serious injury, or violence. The key features are things like persistent re-experiencing of the event, flashbacks, intrusive memories, nightmares. Then there's persistent avoidance of anything linked to the trauma. Plus, negative changes in thoughts and mood like persistent fear, horror, guilt, or shame, and emotional numbing. And finally, persistent symptoms of hyperarousal, being jumpy, irritable, having trouble sleeping, always being on guard.
And these symptoms have to last.
For PTSD, the symptoms need to last for more than 1 month. And importantly, sometimes the onset can be delayed. Symptoms might not fully emerge until months or even years after the event. It shows how deeply trauma can be buried.
Wow. Okay, so we've talked about the intense physical symptoms that can show up, especially in moderate to severe anxiety and in trauma responses. Let's touch on how the mind and body try to cope. We mentioned dissociation, but there's also somatization, expressing stress physically.
Yeah, somatization is a really important concept here. It's basically the expression of psychological stress through physical symptoms. Sometimes these symptoms don't have a clear medical explanation. It highlights how powerfully anxiety, depression, and trauma can affect the body. Disorders like somatic symptom disorder, illness anxiety disorder, where someone is preoccupied with having a serious illness, or conversion disorder, where you see neurological symptoms without a neurological cause. They all reflect this mind-body connection where psychological distress manifests physically.
And then there are the everyday ways we manage anxiety defense mechanisms. The sources emphasize these are normal, right? We all use them.
Absolutely. They're unconscious strategies our ego uses to protect us from anxiety, or things we find hard to cope with. Things like denial, just refusing to accept reality, or rationalization, creating logical excuses for unacceptable behavior, projection, seeing your own unwanted feelings in someone else.
So they're not inherently bad.
Not at all. Some are quite adaptive, like sublimation channeling unacceptable impulses into socially acceptable activities, or suppression, consciously deciding to put troubling thoughts aside for later. They only become problematic when we rely too heavily on the more immature or reality-distorting ones, and it prevents us from actually dealing with the issue. Understanding them is key for therapists.
Which logically leads us to treatment. If avoidance and unhelpful coping mechanisms are central problems here, what's the main way we help people confront these things safely?
The absolute cornerstone, the gold standard treatment, especially across the anxiety disorder spectrum, is cognitive behavioral therapy, or CBT. The core idea is pretty straightforward. Our thoughts, feelings, and behaviors are all interconnected. So if you can change your thinking patterns, you can change how you feel and what you do.
How does it work in practice?
It combines cognitive therapy, things like identifying and challenging negative automatic thoughts, psychoeducation, with behavioral therapy techniques. That includes relaxation training or systematic desensitization, where you're gradually exposed to feared situations, sometimes even flooding, which is more intense exposure.
And for OCD, there's a very specific type of CBT, isn't there?
Yes, highly specific and very effective. It's called exposure and response prevention, or ERP. You work with a person to deliberately encounter the things that trigger their obsessions, the feared object, the intrusive thought that's the exposure part. And then, crucially, they make a conscious effort to not do the compulsive ritual that's the response prevention. Over time, they learn the anxiety does decrease on its own without the ritual, and the urge lessens.
Okay. What about medication? What are the options there for quick relief versus long-term?
For rapid relief, like during a panic attack or severe anxiety, anxiolytics, particularly benzodiazepines, are often used. Drugs like lorazepam or clonazepam, they work fast by boosting GABA, which is like the brain's main calming neurotransmitter. It dampens down the nervous system's activity.
But they have downsides, right?
Big downsides, yes. The major concerns are the risk of dependency, tolerance, meaning you need more for the same effect over time, and addiction. Plus, they can cause sedation and increase the risk of falls, which is a particular worry for older adults. So they're generally intended for short-term use.
So if someone needs daily, ongoing help without those addiction risks, what's the alternative?
A common non-benzodiazepine option is buspirone. It works differently, doesn't cause dependence, and can be used long-term. The catch is it's slow-acting. It can take, 2 to 4 weeks to really kick in. We also heavily rely on SSRIs, the antidepressants, as first-line treatment for chronic anxiety like GAD and panic disorder. They work well for many people. And sometimes beta blockers are used not really for general anxiety, but for specific situations like performance anxiety or stage fright. They don't reduce the psychological worry, but they block the physical effects like rapid heartbeat and trembling.
Okay. Wow. We've covered a lot of ground. So what does this all mean for us? We've journeyed through the anxiety spectrum, from that helpful mild state right up to debilitating panic. We've untangled GAD's worry from OCD's rituals, look at trauma's impact via ASD and PTSD, and seen how the mind and body connect through somatization and defense mechanisms.
I think it means we have a clearer picture of just how widespread and impactful these conditions are. As we said, anxiety disorders are the most prevalent mental health issue worldwide. And that statistic from the sources that hospitalization rates for anxiety are actually highest among adults aged 65 and over, that really says something about the potential long-term cumulative toll of living with chronic anxiety across a lifetime.
Yeah, that's sobering. Definitely makes you think about prevention, doesn't it?
It really does. Which leads to maybe a final provocative thought for you, our listener, to mull over. Given how common these disorders are, and knowing they arise from this complex mix of biology, maybe childhood experiences, stressful life events,
Yeah.
what's the potential hidden cost to us as a society of sort of normalizing chronic low-level anxiety? And how early should we really be focusing on teaching effective coping skills, building robust support systems to try and mitigate that risk across a person's entire lifespan?